normal other system with a normal. So, what do you think? Okay. So, then we will take exactly in the same way as we did in the previous piece. Okay. What is this investigation? Dilated IHBR and CPD is also dilated. The left side IHBR, right is in the gallbladder, and CPD.
Good evening, Pankaj bhai.
Good evening, sir.
Yes, as soon as apna Ganesh Bakshi is just joining. Once he joins,
Sure.
we'll just start it. 1 minute, 1 or 2 minutes.
Sure.
I think we should start. Ganesh Bakshi will join. Who is answering today?
Is Dr. Gite
Rahul
joining?
Rahul from Dhule, sir.
Good evening.
Good evening, sir.
I am Dr. Rathore
Yeah.
from
Acha, Dr. Gite is
Delhi.
okay.
Okay. Rahul and Rathore.
Yes, sir.
Okay.
Sir, for the first case, there will be Dr. Anuj and Dr. Harsh.
Hello.
Good evening, sir. Anuj from Puttaparthi, sir.
Okay, fine. So who two are answering today for this case?
Sir,
Dr.
Rahul.
Anuj and Dr. Harsh.
Rahul and Rathore, first case. Okay.
Okay,
Yes.
sir.
Yes.
Okay. Yes, Rathore, you can start.
Sir, my case is 82-year-old male present with the complaint of painless hematuria since 1 month, increased urinary frequency since 15 days.
Sir, I would like to elaborate the chief complaint. That is hematuria, with its
Yes.
onset, duration, progress. Whether hematuria is gross or non-gross, then sir, whether it is painless or painful hematuria.
No,
Whether it is,
history is given.
yes,
Right. History is given. Just read it.
then patient was relatively asymptomatic before 1 month. When he noticed passage of blood in urine, it was sudden in onset, painless, non-progressive, and self-limiting. Hematuria was complete, associated with passage of amorphous clots. Hematuria since 1 month, complete, intermittent, associated with passage of amorphous clots. Patient also had increased urinary frequency since 5 days. IPSS score is given. IPSS is 12, sir. Symptom was insidious in onset, gradually progressing with non-specific aggravating and relieving factors. So there is no history of lithuria, no history of colicky pain at the time of hematuria, no history of previous instrumentation on catheterization, no history of abdominal pain, vomiting, no history of jaundice, facial puffiness, exertional breathlessness, lower limb edema, no history of backache, bony pain, weight loss, no history of bleeding disorder, anticoagulant therapy, blood transfusion, no history of radiation or chemotherapy. Sir, then I would like to ask personal history, past history and family history of the patient. History of hypertension and diabetes since last 13 years on tablet telmisartan 40 milligram once a day and injection plain insulin 8 units, 10 units, 8 units. No history of tuberculosis, hypothyroidism, hyperthyroidism, no allergies. Family history not significant. Personal history, diet, mixed diet, appetite normal, bowel and bladder, sir, bladder altered, hematuria, increased frequency, bowel regular and normal, sleep is normal, habit, no addictions, non-alcoholic, non-smoker. Sir, sir, 84-year-old male patient with painless hematuria associated with increased frequency with sir, with this history, I would like to keep my differential diagnosis as a bladder mass, whether it is benign or malignant, prostatomegaly, then sir, I would like to keep prostatomegaly with vesicle calculus, as well as, sir, I would like to keep differential diagnosis upper tract urothelial carcinoma, as well as, sir, renal cell carcinoma with prostatomegaly. And sir, I would like to keep as a infectious cause, that is UTI, is one of the differential diagnosis, as well as, sir, genitourinary tuberculosis in this patient. Then, sir, I would like to examine my patient, sir.
So you agree with him or you have some different idea?
Sir, I'm agree with him, sir. My first diagnosis will be the bladder mass, there's a benign or malignant, and then my DD will be upper urothelial carcinoma or any upper tract tumor, either RCC or your UTUC, sir. And then the prostatomegaly with the vesical calculus.
So, can you name some benign bladder masses?
Sir, Von Brun nest, sir, cystitis cystica, then, sir,
Leiomyomas.
leiomyomas and papillary tumors, sir.
Papillary tumors, matlab?
Benign papillary lesions, sir.
Okay. Histopathologically, they are inverted papilloma.
Inverted papillary.
Yes, sir, inverted papillary.
So, not all these what you said present with hematuria. Itna yaad rakho.
Yes, sir.
Okay.
Yes, sir.
I mean, the other benign can be a few in the bladder vagare also,
Yes.
but not all present with hematuria. Okay, go ahead.
Then, sir, I would like to.
This age was 83, right?
Yes, 83 years.
I don't know.
82.
82.
Sir,
पंकज सर है ना, तो प्रोस्टेट नहीं बोलने का ना सर पहले.
You see, I have a couple of objections. Why have you thought of upper tract diseases?
Yeah, agreed.
Sir, as age 82-year-old male patient with painless hematuria, we can keep one of the differential diagnosis of upper tract urothelial carcinoma.
But will upper tract present only with lower tract symptoms?
No, sir. It may be associated with the prostatomegaly or bladder.
अभी upper tract की बात कीजिए. Will upper tract malignancy present
Sir,
only
no,
with
sir.
lower tract symptoms?
No, sir.
Then why have you kept that as a differential diagnosis?
Sir,
You see, understand one thing. Don't try to really focus on any disease at this time. On history, we only focus towards the probable organ of origin. Upper tract, lower tract, right, left.
Yes, sir.
Okay. So old man, 82-year-old man presenting with lower tract symptoms and painless total hematuria with amorphous clots. I am looking at some lower tract pathology.
Yes.
Okay, which could,
Yes.
whatever you think of. I would not really like to keep a diagnosis of upper tract malignancy at this time.
Okay.
And sir, whether we can keep renal cell carcinoma or renal mass with prostatomegaly concomitantly in this case, sir.
You see, most patients with renal mass, most men with renal mass who are older will have prostatomegaly. So prostatomegaly in itself is not a diagnosis.
Yes.
We need to talk of bladder outlet obstruction. So
Yes.
Does this patient have significant lower urinary tract symptoms?
Sir, only, sir, is IPSS score is 12, sir.
12. Fair.
Yes.
So don't get really too deep into differential diagnosis at this time, because unnecessarily your discussion will remain on the differential diagnosis.
And history only.
And history only. So it is extremely important.
Unless you are asked, don't commit.
Yes.
Yes.
Based on this history, if I am seeing this patient in OPD, what will I think? Older man, hematuria, lower tract symptoms. I want to look for pathology in the bladder or below. I would be surprised if this patient turns out to be RCC upper tract UTUC. Those don't present like this.
Yes.
Chali, so what next?
Sir, I would like to examine the patient. Patient is
And
conscious.
my second Rahul, last time also I told you. You see, what happens is when you read it, everybody's reading speed is much faster than your reading speed, your talking speed. So आप एक second में उसको पढ़ो and just give the inference.
Yes.
Like I would look at it, मुझे इसमें क्या क्या देखना है, मुझे hypertension है कि नहीं उतना देखना है. I would read it and say general examination normal. Next slide.
Yes, sir. Sir, in this patient, general examination normal. Per abdo
आप पढ़ो
examination.
और सिर्फ inference दो हमको.
Yes, sir. Sir, per abdo examination, inspection appears normal, sir. Then I would like to do palpation of the patient. Palpation is also appears normal. Then, sir, systemic examination, I would like to see, and local examination. Per rectal examination, sir,
Normal.
grade 1 prostatomegaly, firm inconsistency.
In a patient where you have a lower tract pathology, don't miss digital rectal examination.
Yes, sir.
That
On
would be
digital,
an absolute criminal mistake.
yes, sir. On digital rectal examination, prostate grade 1, firm inconsistency. Rest of the findings normal.
Next.
Next, sir, 82-year-old male. I would like to summarize the case, sir. 82-year-old male patient with painless gross hematuria with increased frequency, and sir, general examination normal, and per abdo examination normal. On digital rectal examination, grade 1 prostatomegaly. Then, sir, I would like to keep the differential diagnosis. One is bladder mass first, then, sir, bladder outlet obstruction, whether it is due to the prostatomegaly, sir.
What next, Rahul?
Sir, in next, I would like to do the routine routine investigation, urine routine microscopy. Then, sir, complete blood count. Then, sir, renal function test with serum electrolyte, and sir, then urine cytology. Then, sir, as an extension of clinical extension, I would like to do USG abdomen and pelvis, sir. And after that, I would like to do uroflowmetry for this patient and serum PSA also.
Okay, the question is that
Yes.
in this patient, you will like to do directly CT, CT, abdomen, pelvis, all contrast,
Sir, first,
because he has got hematuria. Otherwise, also, you are going to do it or not?
no, sir, I would like to do first ultrasonography of abdomen pelvis. Look for bladder lesion. Then I would like to decide on sir, CT scan abdomen pelvis with IVU.
Rathod, can you just explain what is your view, how you are going to go ahead?
Sir, firstly, if the patient's renal function test is normal, I want to do the ultrasound only, sir. It will tell me is there any tumor, what type of tumor, if there is any lesion in the bladder, what is the size of the lesion, if there is a hydronephrosis is there or not. So I want to do the ultrasound first, sir. And if it's required, then I will do the CCT.
I have a question. Why is everybody focused only on bladder? Why can't it be from the upper tract?
The ultrasound will suggest us any upper tract lesion or any from the kidney or from ureter or from any bladder. It will tell us the prostate size also. Or any
so in the differential diagnosis, the hematuria could be from the upper tract also. It did not be only from the lower tract.
Yeah, sir, possible, sir.
Okay, go ahead.
Is that Balchandra? Who is that?
Yes, hi,
Hi,
Pankaj.
Balchandra.
Hi, hi.
Balchandra, before you joined, because this patient
Sorry.
came with pure lower urinary tract symptoms and hematuria.
So it was
So
on the lower track, everybody was targeting.
rather, I had suggested that because history has shown only lower tract symptoms and hematuria,
Okay.
we would really not keep kidney as a probable differential diagnosis.
Okay. I joined late, so I was trying to ask that.
Yes.
Okay.
Sir, urine routine hematuria is there, sir. Then, sir, renal function test and complete blood count. I would like to see, sir.
No, so Balchandra, the
Yes.
question is that in exam, some
Hmm.
examiner may tell them that why you want to do sonography when patient is having hematuria, directly go for a CT scan. So the thing is, if they are saying ultrasonography, how to justify?
Ultrasound, as Pankaj said, everybody said, it would be a basic, it will guide us how things are going. So there is a good value in doing an ultrasound. If an ultrasound shows picks up stones, hydronephrosis, we know what's the creatinine and all that. So all those information. If ultrasound shows bilateral hydronephrosis with stones and the creatinine is high, where is the question of doing a CT?
Further, sir,
I think
this presentation could very well be because of, say, a multiple vesicle calculi.
Yeah, could be.
Even bladder
Could be.
stones can present with hematuria and increased frequency and urgency.
Yes.
So you should do a sonography first before you decide. Means, Rahul, like you started off asking for cytology also. I would not, in the first interview with the patient, ask for cytology. I would get CBC, urine routine, creatinine, and sonography. Once sonography tells me what is the likely disease, then I think of how to investigate further.
Yes.
The other thing with cytology is in presence of a gross hematuria, it may be difficult to interpret.
Yes, sir.
Yes.
So what is the common take of the examiners like? Because matlab, if there is a episode of no hematuria, then cytology works.
Yes. So
And with
I will
some
say
expert
that in,
pathologists who do centrifuge and see it
Yeah,
works there also.
they will need to centrifuge it and then only they can look at that.
Sir, in exam, then should we tell?
yeah. See, in
using
exam,
cytology?
what you can do is
I think
you can say
there is
that
no gross
I will like to
hematuria. I'll
do
find a window and send urine cytology.
exactly.
Okay, sir. Yes. Sir,
Okay.
complete blood count looks normal. Renal function test looks normal, sir. HbA1c 6.7. Then, sir, I would like to see serum PSA and if urine cytology is present.
Serum creatine is 9. Calcium
1.13.
1.13 and calcium 9.9. Hemoglobin A1C is slightly higher size.
PSA is 1.2.
Sure.
Then, sir, I would like to see the USG plates of abdomen pelvis.
We have the reports.
Okay. Sir, right kidney and left kidney appears normal, and bladder is distended, circumferentially thickened, and irregular urinary bladder wall with maximum thickness 9 mm. Ill-defined heterogeneously hyperechoic mass lesion at the left lateral wall within the lumen is likely infiltrate the bladder wall, measuring 28 into 23 into 35 millimeters. The lesion shows minimal internal vascularity on color Doppler. Prostate is 22 cc, sir.
Okay.
So
Anything else you want to see on, matlab, you feel important on the sonography?
there is no hydronephrosis, no vesicle calculus. There is ill-defined mass originating from the bladder walls.
Okay. How do you differentiate mass from a clot in sonography?
Sir, clot is hyperechoic and it may be mobile.
Mass is also hyperechoic.
And sir, it will mobile and doesn't have any vascularity in it.
Clot may not be mobile.
Sir, clot doesn't have any vascularity.
Vascularity is the last thing on Doppler.
Sir.
Sir, patient may have history of acute retention.
The bladder mass and the bladder wall have the same ecogenicity, sir. So and clot don't have that, and it's a continuation of the bladder wall mass.
Do we have the films? Do we have the
Sonography-
ultrasound films?
No,
For this case, we
ultrasonography
don't
films
have,
no.
sir. Next case, we have.
How do we proceed further?
Sir, yeah, as ultrasound suggests, the mass is around more than 3 centimeter. So in that case, I want to do the CCT KUB abdomen and pelvis, sir.
Okay.
To see any
Hey, don't say that. We'll see the CCT, but when you say
synchronous
that in the exam, at least, matlab, it's so many times we have
Sir,
gone over this. At least say what phases and all you want to see.
Sir, I would
sir.
So
like
please
to,
show the CCT.
Sir, I would like to do
I want
multi-phasic
to see the
C contrast and CT
You read
scan.
this CT. एक बार exam में ना chance गया तो गया रहता है. अभी let us
I
continue
want
this
to do
attitude now.
phase.
If you want to present, try to present in the best way.
Yes, nowadays we are having a presentation for exam. So you will not get, like, this is not a, we are going to discuss in detail. So how you appear in exam. So we are preparing you for that. Okay. So as Dr. Ganesh Bakshi said,
मतलब
once you
say
give the
once for
chance,
all. मतलब
yes, yes, once
we are
you
not
give
giving
the
you
chance,
3
you
chances here to speak and practice here.
correct.
Somebody is reading the CT.
Sir, this is the sir, axial cut of CT scan on the right side, which is plain film in which, sir, the bladder is distended with the right lateral. There is a hyperdense lesion, which is single, and
Left lateral.
yes, sir, left lateral. Sorry, sir, left lateral. There is single lesion around 2 centimeter into 2 centimeter with hyperdense lesion, and sir, bladder looks distended. Then, sir, sir, around the fat planes around the bladder looks normal, sir. There is no obvious lymphadenopathy seen. And sir,
Where are you seeing the lymphadenopathy?
sir, in the pelvis, in the pelvis.
So you started off saying it is a plain film. I don't know, but I am seeing in a laptop, so I can't zoom it. But I see contrast in those vessels.
Yeah, there is a contrast in the vessels.
And then you started saying it is a plain film.
It's not a plain film.
This is the arterial phase of the
Yeah.
capacity.
So don't make these mistakes in exam. मतलब,
Yes,
we can evidently see that it is an arterial phase.
Okay, sir. And sir, upper tract, kidney, and rest of the abdomen appears normal, sir.
Are you happy with the films? Do you want more films?
Sir, I would like to see CT urography films also, sir, as well as if HRCT chest has been done, or then I would like to see that also.
Why do you want a HRCT chest? Let's first
Sir,
focus on this only.
yes, sir.
And for a 3 centimeter lesion, is it a routine policy to have a CT TAP?
Sir, for metastatic workup, we can.
So every small bladder lesion, you are going immediately for a metastatic workup?
Sir, chest X-ray can be suffice for the metastatic workup also.
I don't think this is the right time to speak about metastatic workup. You are putting your foot into a big khadda. Okay?
Yes.
Honestly telling you. Here you are told to read the CT for the local lesion. Lymph node
Yes.
is acceptable.
Yes,
वो
sir.
chest बीस मांगना नहीं. You are not seeing the 4 phases right now. Arterial,
Yes, sir.
बोलो.
Sir, this is contrastinous axial cuts of abdomen. Sir,
नहीं,
in
don't
which,
repeat. वो,
yes,
if you are repeating, then let the other person speak.
sir, then CTIVU films.
Why do you want a CT IVU?
Sir, I would see the upper tract also and ureter also, whether
Okay.
any lesion, concomitant lesion is there or not.
There's no hydronephrosis, you said, right?
Yes, sir.
We can see a bladder lesion. What is the chance of a upper concurrent lesion?
Sir, 2 to 4% can be
Correct.
present as a
It can be.
concurrent lesions.
Anything else on the CT?
So there is no there is no there is no liver obvious, or there is no liver mets. There is no liver mets, or there is no ascites.
So you have to say visualize liver appears normal.
Visual,
Choose your words properly and carefully. I
sir.
don't see any free fluid.
Okay, sir.
Okay.
Also comment there are no clots in the bladder, obvious.
No clots in the bladder.
Okay, sir.
And ask for delayed films if you want. नहीं है तो
Rahul and
just
Dr. Rathod.
person who is managing the CT, can you have more films if possible?
Sir, unfortunately, the patient had came from outside.
No problem, no problem. Then you put the next thing. I think they have exhausted what they want to say. The right kidney is small, 7.6 by 4.2. Left kidney is slightly better, 9 by 4.2. Urinary bladder shows a mass, irregular soft tissue density.
Measuring.
With significant post-contrast enhancing, 23 by 23 by 17, almost the same size as seen in the sonography. And they have mentioned perivesical fat planes are well maintained. So, Rathod, Dr. Rathod,
Please.
do you think MRI would have been better here?
Sir,
Your answer is
yes, sir.
question is
Yes,
simple. Do you think MRI would have been better?
sir, MRI would have been it's better, sir.
Why?
Because MRI will help us to identify muscle invasion or not, sir, with the virus scoring. CT scan is in CT scan is very difficult to differentiate between on the stage of tumors.
Okay.
Why MRI? Why not PET CT?
Sir, PET CT have a low PET CT have a low sensitivity and specificity for the staging purpose, sir. And the layer of bladder wall is better visualized in soft tissue, is better visualized with the MRI, not with the PET CT.
Okay.
So PET CT, what happens is the contrast is also excreted in the urine.
Sir.
So sometimes if the bladder lesion is going to take up a hot spot, higher SUV, it almost matches the SUV with the urine. So sometimes some people cannot differentiate, but then you are supposed to empty the bladder and then take a film on the PET.
Post-void film.
Post-void film. But overall, we don't talk about PET here. The question was between MRI and CT. So, Rahul.
Yes, sir.
What type of MRI is ordered if we are supposed to do an MRI?
Sir, multi-parametric MRI can be ordered, in which
Okay.
T2, yes.
And how is the muscle layer seen?
Sir, muscle layer is hyper intense.
Can you talk a little loudly, please?
Sir, muscle layer is seen as a hypointense lesion, sir, on
Hypointense.
T2-weighted film, sir. And
T2 it is seen hypo. Muscle layer is seen as a black line in T2. Okay, hypo, that way you're saying.
Yes, sir. Hypointense lesion.
So it is better is to say a black line. It's seen as a uniform black line around.
Yes.
Which is technically, you're right, hypointense. But it is not a lesion. It's seen like a line.
Okay, sir.
Okay.
Yes.
How accurate is the wired staging?
Sir, sir, I don't know about that accuracy data of
Find out.
wire
Find out.
Sir,
And if at all you have to do an MRI, when should you do it? Before TURBT, after TURBT?
sir, it should be done. Ideally, it
Sir,
should be done
before
TURBT.
TURBT.
Or if you want to do the after the TURBT, then at least 6 weeks after the TURBT.
You should know what happens if you do it soon after TURBT.
There
Sir,
will be a post-operative inflammation or edema at the tumor site, and it will be difficult to differentiate between the bladder walls layers from the MRI. So
You can still go Karjat Varjat या कुछ जाके आ सकता है.
In this patient, if you had seen a mass on
Sunday को day
ultrasound
tip बनाए
on
क्या?
the lateral wall, you could have straightway asked for an MRI. MRI with MR urography, something like that.
हम Saturday और night ही निकल सकते हैं. मैं थोड़ा जल्दी आ जाऊंगी 7
Hello,
बजे
please stop talking.
What do you want to do now, Rahul?
Sir, I would like to counsel my patient regarding the diagnosis and treatment options, sir. Sir, I would like to do cystourethropy with TURBT for this patient, sir.
Anything else?
Sir,
urine.
With bimanual examination.
Bimanual.
Under anesthesia.
Sir, is there any role of bimanual examination in current era, sir? Because a lot of confusion are there. A lot of says will say that when you done the CT, there is no need of doing a bimanual examination before TURBT. So because you know the staging before you go for a TURBT, sir. Because so should we say that bimanual examination followed by the TURBT pre and post TURBT bimanual examination, or would actually should say the TURBT, sir?
So what you are saying is right, that in today's time, bimanual examination usually does not add much to your decision making.
Sir.
This was important when CT scans were not freely available. But as a protocol, when you discuss TURBT, talk about it.
Okay, sir.
You don't want the discussion to enter into bimanual examination. So the way I would have said this is, I would do a cysto TURBT bimanual examination under XYZ anesthesia with tumor based biopsy. सब कुछ एक साथ बोल दो ताकि हम आगे बढ़ सके. ठीक है. अदरवाइज नेक्स्ट क्वेश्चन आपको पूछा जाएगा एनेस्थीसिया कौन सा लगे, नेक्स्ट पूछा जाएगा बायोप्सी करोगे या नहीं करोगे, रैंडम बायोप्सी करोगे या नहीं करोगे. So the more you talk precisely in one sentence, you reduce the number of questions asked, and more likely we go into a slightly higher discussion, which probably will be scoring discussion.
Right, sir.
Pankaj sir, this is Dr. Amit Agrawal here, sir, from RR Hospital.
Yes, Amit, tell me.
So regarding this bimanual palpation, isn't it high time we get rid of this and tell our students to avoid telling this in exams?
Amit, if you ask me, do I do bimanual examination? The answer is no.
Yes, yes.
But the question is that we want to get them through exam to a better part of discussion. Means you see, the moment he did not say, Rahul did not talk about bimanual examination, one of the examiner asked, और क्या करोगे?
Understood, understood.
तो इसमें से आप बाहर निकल जाइए जल्दी से. फिर अगर एग्जामिनर पूछते इसकी जरूरत थी क्या, तो बोले नहीं ये टेस्ट है, अभी नहीं करते, अभी जरूरत नहीं है.
Okay.
This must
Just to wriggle
easier
out of it and go ahead in the discussion.
in
That's
the
about it.
discussion. Yes.
Absolutely.
So
Absolutely.
I don't want the student to get stuck at bimanual examination.
Absolutely. Absolutely, friends. Thank you, sir.
Okay. कुछ finding है?
Can you briefly describe us the steps of the TURBT?
हाँ चलेगा best.
Yes, sir. Sir, I would like to give the position anesthesia, preferably general anesthesia with obturator block, IV antibiotic. Then I would like to start the cystourethropy, see any lesion present in prostatic urethra or not. Then I would like to see any. Sir, I would like to see number of the lesions, area around that lesion, ureteric orifices involved or not, trigon involved or not, anterior wall, as well as dome. Then, sir, right and left lateral wall, I would like to see, sir. Then, sir, I would take the dissection with piecemeal dissection using cutting current and preferably intermittent cutting current with the use of bipolar. I would like to resect the tumor by piece. Then after that, I would like to collect the specimen and send it for histopathology.
What is this intermittent cutting current?
Sir, cutting current, sir.
What settings?
Sir,
You are talking monopolar or bipolar?
Sir, bipolar usually which reduces the chances of lateralization of the current and avoids the obturator jerks. And sir, setting is 40, sir, 40 and 60.
40 and 60. Bipolar setting you are telling me.
40 is what?
Sir,
So what was the setting kept when you last did TURBT?
sir, sir, cutting at 40 and coagulation at 60, sir.
Yeah, Bhargav. Hello, Bhargavi, can you just mute yourself? Yeah, go ahead.
Bipolar is not available. You have to do a monopolar cautery. Use a monopolar cautery. What setting? Have you done a TURBT with monopolar?
Monopolar, what settings you will keep?
Sir, monopolar, sir, I don't have idea on the settings.
So for a TURP, what settings you keep?
The other candidate can answer.
Sir, sorry, I don't know about monopolar cautery settings. So
You both don't
No.
know. I really think you should know that for your exam, and if you don't know, probably it's wrong.
So,
See, most of the places there is monopolar available, number one.
And wherever
So
there
for
is
a
a bipolar instrument, the settings are already set into the system.
Yeah. See, so for a TURP, normally we keep 120/80. But for the bladder, normally we like to keep it 100/70 or 100/60. If needed. And second thing, what type of loop you will like to use in monopolar? Thin or thick?
Sir, thin loop.
So long, if it is a used thin loop, it is better.
Yes.
Correct?
Yes.
Okay. Now, in a monopolar, if you are getting just tell me how you will try to avoid it.
Sir, sir, I would like to tell my anesthetist to give muscle relaxant, general anesthesia, as well as obturator block.
You
As
started with
after
the
that,
regional and obturator block, no?
yes, sir.
So again, now you'll convert to a JA. You should decide something right at the front, no? Whether you want a GA with a muscle relaxation, or you want a, if you can't be given a GA, you want a regional with a obturator block.
Sir, sir, GA with muscle relaxant or sir, regional with obturator block can be sir possible.
So what
Then,
Dr. Gaurang Shah asked you is how do you avoid the obturator jerks?
sir, then while doing the TURBT, I would like to keep the bladder partially filled. Then use monopolar. Then, sir, piecemeal resection. Then, sir, I would like to keep irrigation flow. Inlet is half and outlet open, sir. These are the ways I would like, and yes, sir, these are the ways I would like to do while doing TURBT, sir.
Have you
Yes, sir.
the obturator jerks with the bipolar?
Sir,
You are bipolar, no?
yes, sir. Sir,
Now,
there are less chances of the
I
current.
didn't ask you chances. I asked, have you seen or not seen?
No, sir. No, sir. I have never seen
I have seen. So many times when the bladder is slightly extra filled, the obturator jerk comes because of a direct stimulation of the nerve. You are with a fixed mentality that it is the current traveling and stimulating the nerve. That is why you said no right now.
Keeping bladder less distended is the principle throughout.
Yes.
Whether you do a monopolar or a bipolar. And if you were talking, you have not seen monopolar, only bipolar, the next question examiner will ask, what about a laser TURBT? What about an en-bloc TURBT? Pankaj does so many en-bloc TURBTs.
Yeah,
So
so
at least monopolar TURBT, you should know the setting. You can't say I have not seen.
For exam, you should know. You can't say
Yes.
not seen.
Yes.
No, nobody will pardon that.
Yes.
Examiner will simply consider
next
that.
question is, the next question is, you like to do end block resection or not? And what are the advantages?
So in the answer, you should quote a meta-analysis.
Sir, if pedunculated mass is present and solitary lesion is there less than 3 centimeter, then we can go for en-bloc resection, sir.
And why you want to do end block resection?
En bloc resection, if you do the en bloc resection, the chances of muscle in the specimen is higher, sir. So it the sensitivity will be higher.
Can you do an en-bloc resection with monopolar or a bipolar or only with laser?
We can do with the laser and with laser also with the bipolar or monopolar also.
Any changes you need to do in your loop?
Pardon, sir?
Any changes you need to do in your loop if you're using a monopolar for an en-bloc resection?
You have to it should be thin loop, sir, and should be once you mark the tumor.
He has asked you, will you like to change the shape of the loop? Do you manipulate the loop or not? You keep the same way or you manipulate it? Because you want to do en bloc dissection?
You have to give slightly, make some angle.
Which way? Angle inside or angle outside?
Which angle? Angle the outside, sir.
You need
So
to
we-
straighten the loop. The curve which is there, you will need to straighten it.
So we can go
So you can go under the base.
base, sir.
Because
yeah.
most of the time you are going to cut from below up. You understand?
Sir.
Hey Siri.
Pankaj bhai, you have done lots of cases and you have presented also. Can you just enlighten them with
So you see, en bloc resection, Rahul, as you rightly said, is reserved for tumors smaller than 3 centimeters, which are within 2 centimeters of the ureteric orifice. Anterior wall and dome is a difficult site.
Correct.
There are reports of en bloc excision of larger tumors, but if you do larger tumors, then you will not be able to get the tumor intact through the resectoscope sheath. So you may need to break the tumor. So the advantage of doing en bloc is lost. But then people have done en bloc resection of larger tumors using a morcellator or then cutting that into controlled multiple pieces so that they can be removed. Theoretically, it is supposed to reduce the tumor cell implantation. You are likely to get more chance of getting higher chance of getting retrusor muscle, and it is probably a more complete removal of tumor. But up till now, literature has not proven no study has proven that the risk of recurrence dramatically reduces by doing en bloc resection. So the idea of en bloc resection is, otherwise any other malignancy, you would not want to cut the malignancy into pieces before removing it. Bladder tumor is the only malignancy where you break it into multiple pieces to remove it. En bloc resection takes care of that. You will get a much better tissue for histopathology. Once you remove the tumor, it is important to ink the bladder end of the tissue and then send for pathology examination. When we are doing en bloc resection or any bladder tumor resection, we are interested both in the vertical depth as well as the lateral extent of the tumor. So if you go 3 to 4 millimeters away from the tumor, you will be able to get the complete lateral extension as well as a very good idea about the depth of the tumor. So theoretically, it looks a good technique, but literature is yet to prove this. Which energy sources can be used? All 3 lasers have been used. Holmium, TFL, thulium laser, all 3 have been used. Then you can use electrocautery. What is his name? Dr. Hamid. He has devised a scissor, a cauterized scissor, which can be used to cut around the tumor and get the tumor out. There are techniques of using a snare basket. So you inject saline below the tumor, elevate the tumor up, then put an electrocautery snare and cut it off as an intact tissue. So multiple techniques have been used, but commonly it is done by one of the laser techniques.
Yes.
So we have recently acquired water jet also, sir. That is also
Yes.
being used to do
Yes,
en bloc resections.
absolutely. Absolutely.
Sir, I don't know about any meta-analysis or systemic review on the en bloc resections.
Okay, you have the histopathology. Let's move ahead. You have the histopathology. Are you happy with the report?
what
Yes,
are
sir.
the things you are looking for? When you are asking for a histopath report, what you want to see?
Sir, we want to see the grade of tumor, is it low grade or high grade? Is the lamina propria invasion is there or not? Deep muscle is if present or not? If it's present, it's involved or not? Or any there is any CIS component is there or not in the tumor?
And sir, any variant of histology?
Variant histology also, sir.
Like sir, sarcomatoid variant, micropapillary variant, nested, or plasmacytoid variant, sir.
Anything else?
So you should be very specific. It says submitted tissue free of tumor. Was that tissue, was the muscle present or not? And was it involved or not? Now, this is a little vague. Submitted tissue free of tumor. Was it a muscle or not? I would want my pathologist to report very specifically.
Yes, sir.
It does happen. We take a biopsy as a deep muscle and the pathologist says there's no muscle in that. So what do you want to do?
Sir, then after
So,
TURBT,
1 minute. You finish the TURBT and this histopathology has come after 3 days,
sir,
right?
yes, sir. Sir,
So,
immediately after the TURBT, I would like to give intravesical chemotherapy in the form of mitomycin C, sir, within 6 hours, if possible.
What happens if it is given at 8 hours, 10 hours?
Sir, up to 24 hours we can give, but sir, 6 hours is the best for the tumor cells will get killed more as compared to 24 hours.
Yes, sir.
When would you not give perioperative instillation?
If there is hematuria is there, or or accidentally bladder perforation is there, sir. In both cases, we should not give them mitomycin.
Can we not give BCG immediately?
Sir, no, sir.
No, sir. We should not.
No, sir.
Why?
Because BCG systemic absorption lead to the BCG sepsis, sir, as well as it can be spread hematogenously to the other solid organs. And yes, sir.
BCG is basically a live attenuated vaccine.
Yes.
They are live attenuated bacilli. So if there is a perforation, if there are any open vessels, likely systemic absorption.
Yes.
Generally, BCG is not given. Yes. Any other agent apart from mitomycin? And what dose did you tell? You did tell me the dose.
Sir, 40 milligram.
So,
mitomycin C is 40 milligram, epirubicin 50 milligram, and doxorubicin also 50 milligram, sir.
Epi and doxy are the same.
Yes.
How is it given? To be very specific quickly.
Sir, intravesically given with the catheter in 50 ml of saline, indwelling time
Catheter is already
2 hours.
there. Catheter is already there.
Yes, sir. Through catheter, I can connect the gravity-based irrigation, sir.
Gravity-based.
Sir, after the putting catheter, we should drain the urine from the bladder. And
catheter is already there, boys.
Sir,
you have done a TURBT, there is a catheter there.
Sir, we can instill directly the solution of chemo agent, sir.
40 milligram mitomycin in 50 ml of normal saline and insert in the bladder and clamp the catheter for 1 to 2 hours. Sir.
It comes as a...
Pardon?
Sir, voice is breaking.
It comes as a powder or solution. Mitomycin comes as a powder or solution. Do you have to reconstitute it?
It's come in powder only.
Have you used it?
Yes, sir. We are using it.
So how much amount of water we put, diluent?
Is it water? Is it normal saline? Distilled water or normal saline?
What do we use? And what is the amount?
Sir, 40 milligram in 20 ml of normal saline, sir.
अच्छा ये पारस ने बोला है वो कहाँ से मिला ये डेटा 20 ml in 40 milligrams of MMC. Who said that? Dr. Rathod?
No, sir.
Dr. Rahul?
Yes, sir.
How confidently?
40 milligram in 50 normal saline is the...
Google Pixel 6a says 40 milligram in 40 or 50. एकदम बिंदास ऐसा बस मटका लगा रहे Matka is something called potluck. Matka. So the solubility of mitomycin, this you should remember, is 1 milligram in 1 ml of NS. If you use lesser than that, you are going to give powder because it is not going to be soluble and then it is not active. So whatever dose considered in the study is 40 milligrams. So remember, 1 milligram per ml is the required amount for solubility of mitomycin powder. This is given in the incept of that
Insert.
insert, sorry, of the mitomycin injection, which most
Do you know
people
what is the cost of mitomycin? 40 milligram?
No, sir, I don't know, sir.
Find out.
Okay, sir.
You should know that if you are using it regularly. So, okay, this is the biopsy report. What do you want to do further? Patient has come back to you after 5 days. He's all eager to know what you are going to say now.
Sir, for this patient, as it is a low-grade non-invasive papillary urethral carcinoma.
non-invasive किधर lamina propria invasive लिखा है.
वही भी मैं पूछ रहा था.
Who said non-invasive? In the older terminology, this is called invasive urothelial tumor.
Sir, I would like to stratify this patient, and
why don't you want to do a re-TURBT?
Sir, because it is a single lesion and a low grade, and sir,
T1 है T1. You know how many percent of T1 logically are low grade?
Sir, less percentage of T1.
Hardly 3 to 4% of T1 are low grade.
Yes, sir. But sir,
and by the way, your pathologist has reported कुछ तो suspicion है. Submitted tissue free of tumor means pathologist is not commenting on muscle at all. When lamina propria is invaded and there is no muscle, have you read Harry Her's paper? What is the chance of having muscle invasion?
Sir, around
जो कोई literature ढूंढ रहा है डालो chat पे Harry Her's paper for that muscle invasion, re-TURBT.
Yes.
Tell me, you tell me.
Sir, for low grade tumors, sir, if muscle is present and it is free of invasion, then there is no need of re-TURBT. If muscle is present and it is invaded, then there is no need of re-TURBT. But if muscle is present and there is no comment about invasion, we can
You are reading very nicely. Are you quoting some guideline or you're quoting some paper? You're quoting your own mind, it looks like.
So in cases of TA, if we go with the re-TURBT, there is chances of 27% upstage, and if it is T1 lesion, the chances of upstage tumor is around 50%.
This is what? TA or T1?
TA nahi hai, Babu. This is T1, lamina propria invasion seen.
Sir, for this is T1. Sir.
Everybody in the chat is also sleeping.
So T1 hai na?
Even 50% chances of upstage of disease.
So yeah, what do you want to do? 50 is too much. Right?
T1?
Matlab the US paper says that if there is a T1 high grade and no muscle in your TURBT, then the chances of finding muscle invasion on re-TURBT is very high, 55 to 60%. And if you have muscle, still there is a 25% chance of finding muscle positive. That was the old paper of Harrier. So here, what will you do finally?
So I would.
That's what the question is, whether you are going to put BCG or you want to do re-TURBT.
So Rathod, what do you do in your institution? If you are lost anywhere, you always remember what you do in your institution.
Sir, we will do the retest TURBT for this case, sir.
You do a restage TURBT. Rahul, what do you do?
Sir, restage TURBT to correct the understaging of the disease, sir.
So as a procedure in restaging TURBT, restage, re-TURBT, what do we do?
Sir, we go and look for the deep muscle biopsy, deep muscle for the histopathology, sir, and see for the if there is invasion present or not. Accordingly, we can re-stratify the disease, and accordingly that will give us the treatment algorithm.
So it is done under local anesthesia. It is done 1 week after the first TURBT.
Sir, it is done around 4 to 6 weeks after the first TURBT, initial TURBT. It can be done under the, regional anesthesia with obturator block.
So you should say it is generally done 4 to 6 weeks after the first TURBT.
Yes. Yes.
Under
Sir.
proper anesthesia with some muscle relaxation. And what do you do in that? What do you look for it?
Sir, I would like to look for the previous surgery scar, as well as any new lesion is appeared in the bladder.
For any new lesion which you may have missed, or has it appeared? One.
Yes.
And you, what do? You just only look at the scar?
Sir, sir, any area around the scar I would look for, as well as, sir, I would like to take the biopsy from.
You have to resect the scar.
Yes, sir. After resecting the scar, I would like to take the biopsy, deep muscle biopsy there.
You should be very clear how you do a re-TURBT.
Okay.
Okay.
Was a re-TURBT done here?
Sir, मुझे और एक question पूछना है actually.
Yeah, पूछो, please.
So, either of you, do you know any enhanced cystoscopy techniques?
Sir, sir, blue light technique in which photoporphyrins are used, which is selectively taken up by neoplastic tissue.
You name the 4 enhanced techniques.
Sir, blue light, narrowband imaging, optical coherence, and sir, endofocal
ultrasound.
Ultrasound.
OCT, endofocal ultrasound, NBI, and photodynamic diagnosis.
OCT.
Yes,
OCT.
Optical coherence tomography and confocal laser endomicroscopy.
Yes, CLE.
Okay, so which is the most easily available for us in India?
NBI is.
What is NBI?
Narrowband it's narrowband imaging, sir. It's a there is in NBI there will be a 2 wavelength 514 and 420, sir. And then,
pardon?
Sir,
what did you say? 540.
514 and 420, sir. 2 wavelengths.
Okay.
And then the tumor will be visualized brown on the white backgrounds.
Okay. I think the tumor, the capillaries appear dark or brown.
Yes.
Yeah, that will be hypervascularity.
The capillaries appear that way. And so technically, we are supposed to resect all those areas.
Yes, sir.
So studies have demonstrated a significantly increased sensitivity of NBI. So for detecting CIS, it is kind of more than 90% in literature compared to white light cystoscopy, which is 55% around. However, in NBI, apparently in most studies, it did not translate into lowering the 12-month recurrence rate. Somehow. So many people say blue light cystoscopy is one of the best techniques. So coming back to re-TURBT, do we have anything further in this case?
No, sir. Patient has been called.
Okay, itna hi. Okay. So then let's consider that redeorbited deep muscle is free of tumor. How do we manage this?
Yes, Rathod,
Sir?
redeorbit is done, muscle thickened, deep muscle doesn't show any infiltration. Now it is a low-grade, non-invasive papillary urothelial carcinoma.
नहीं सर लैमिना प्रोपिया इन्वेजन है ना
And the lamina propria invasion is.
Sir,
So what is the next step technically?
sir, then I want to risk stratify the
Stratify the tumor, correct.
So it's come under high grade risks because this T1 lesion.
Okay.
So I want to offer if the patient is not contraindicated for the BCG therapy, then I want to offer him BCG therapy for
अभी क्या मस्त बात करते हैं तुम पेशेंट नॉट कॉन्ट्राइंडिकेटेड फॉर बीसीजी थेरेपी अभी वो भी बता दो क्या है कॉन्ट्राइंडिकेशन ऑफ बीसीजी थेरेपी
if the patient have a deranged LFT, if patient have a immunocompromised or patient have a history of any BCG sepsis and
so have you actually read the EAU classification of risk stratification which you said high risk bola na?
Sir.
So when you say T1 but low grade, okay? So
Yes.
what is high risk with T1 low grade?
T1 low grade come under the intermediate grade, sir. Sorry, T1 high grade is high risk. T1 low grade is intermediate risk.
तो बराबर है यार बट पारस किधर गया पारस okay so T1 LG is supposed to be in the high risk criteria with two risk factors, no? So the risk factors are what? They are age more than 70. Then I
Tumor
think
size more
one
than 3
is
centimeters.
tumor more than 3 centimeter. And
Multiple
the
tumors.
third one is multiple tumors. So you are supposed to say that. So इसमें कितने available हैं factors?
2, sir.
So I understand that, but you didn't consider that while classifying it high risk. That is why I made that point here.
Yes,
So
sir.
remember, if you are using the EAU classification, the criteria is with like that. If
Yes,
it
sir.
is straightforward T1 high grade, it is different. But if it is T1 low grade, then it needs 2 risk factors. If it is TA, correct?
Sir.
What needs 3 risk factors? Tell me if I ask you now.
The age sir, if the patient is lesion is less than 3 centimeter, age should be less than 70 and without any CIS, sir.
Okay. It's not like that. It's like TA G2. In the olden classification, there was a G2. So TA, PTA G2. Or in the newer classification, older classification wise, PT1 G1 needs all 3 risk factors to get into high risk. Anyways, I think you should kind of know the EAU risk stratification for that.
Sure.
Let's go ahead. So this seems to be high risk. So what is our choice? That contraindication kya hai VCG ka?
Sir, there is a absolute contraindication. Patient is and relative contraindication. Sir, if patient is immunocompromised, the traumatic catheterization is there. Ongoing hematuria is there, sir.
Okay, before we go there, have you ever heard of any other risk stratification systems?
AU
Something which is available on the mobile.
Sir, EORTC restratification.
EORTC, very good, very good. Any more? At least नाम तो आने चाहिए.
AUA and EORTC, I know, sir.
What is EORTC? Rahul, what is EORTC?
Sir, restratification or long form, sir.
हाँ, लॉन्ग फॉर्म ही पूछ रहा हूँ. पूरा तू बोल नहीं पाएगा. EORTC has a recurrence score and a progression score grossly. But what is EORTC? देख लेना बाद में. What is the other restratification?
Sir, AUA restratification.
AUA, very good. Q2 है. And then एक Q2 है, CUETO, Q2 scoring system.
Spanish है वो, Spanish.
Spanish. Chalo, I think there is one combination of Q2 and URTC also in some publication, but let's leave it. So, आगे चल के क्या करेंगे? Come to the contraindications. You were saying something.
Yes, sir. Sir, absolute contraindication. Patient is immunocompromised. Gross hematuria is there. If traumatic catheterization is there, sir, immediately after the TURBT, and patient is having a history of personal history of BCG sepsis. These are the absolute contraindication. And relative contraindications, sir, if patient is having urinary tract infection, then liver function test is deranged, then patient is having any.
Hello.
Yes, sir.
History of tuberculosis. Prior history of tuberculosis, is it a contraindication?
Sir, yes, sir. Prior history of tuberculosis is a relative contraindication. And if patient is having BCG sepsis history, that is absolute contraindication.
Yes, correct.
How about a patient with
incontinence is also one contraindication.
Yes, sir.
How about a patient with immunocompromised status?
Oh, bola sir, absolute contraindication.
Okay.
Okay. So consider no contraindication or क्या? Hello.
So then I will offer him BCG with as per this SWOG protocol for 2 years. Skip.
Okay. And if there is a contraindication, what will you offer?
Then I will offer him either other than gemcitabine or high-wake therapy, sir.
High-wake therapy. High-wake with what?
High-wake with the mitomycin.
Mitomycin.
C, sir.
So what is the difference between normal mitomycin and high-wake mitomycin?
So in high-wake mitomycin, it's a hyperthermic mitomycin C, sir.
What is the outcome of high-wake?
Hyperthermic intravesical vesicle
therapy. Correct. You are right. Hyperthermic intravesical therapy.
So in the mitomycin, mitomycin will circulate intravesical with the temperature of 43 degree centigrade, sir.
42.
42, sir.
And how much time you circulate?
Sir, for
60 minutes.
1 hour, 60 minutes.
Okay. So basically, you can use mitomycin, you can use gemcitabine. Some people don't use, but some people tend to use gemdosi. and what you said, HIVEC, these are actually techniques to optimize the delivery. Okay. So techniques to optimize the diffusion at the level of bladder mucosa. So you optimize, how you optimize is, you can optimize the urine volume and pH. So simple measures like reducing the liquid intake, overnight fasting. Some
Sir.
people use oral soda bicarb.
So in tablet, desmopressin also can be used.
Can be used.
Sir.
Then another technique is microwave-induced hyperthermia. One second technique is we discussed HIVEC.
Sure.
And last is what is discussed in literature is EMDA of MMC, electromotive drug administration. Okay. So these are enhanced delivery optimizing techniques to give any drug actually, but usually mitomycin has been studied. Side effects of BCG.
Side effect of BCG is BCG is classified in it's a BCG is cystitis, and track symptoms depend on the grade. So it's classified in grade.
Classification, Cleveland Clinic classification. Grade 1, 2, 3.
Grade 1.
एक आधा normal याद रखना मतलब. It's important to remember.
Grade 1, 2, and 3, sir. So grade 1 with the low immunity tracks symptom that lasting less than 48 hours without fever, sir. Grade 2 is low immunity symptoms that last more than 48 hours with fever. Or in grade 3 with systemic features.
Okay. Okay. I am not asking you how to manage that. So what is BCG failure?
So if any patient receiving BCG, if there is a higher recurrence, high grade recurrence during the follow-up of the CP, then it's called a BCG failure.
Okay. Other candidate, you want to add something?
Sir, if there is a T1 grade 3 or TA grade 3 lesion with or CIS lesion, if lesion is appears after the 6 month of induction and maintenance course of BCG, then it is called as a BCG failure.
तुम दोनों ने एकदम different definitions बोल दिया BCG failure के. So first and foremost, you should remember is before failure, the person should have received adequate BCG. So adequate BCG ka you should know what is it. Okay.
Sir, if adequate BCG defined as 5 out of 6 maintenance dose or 2 out of 3
5 out of 6 induction, Babu.
Induction dose and 2 out of 3 maintenance dose.
2 out of 6. Okay. And 2 out of 3 dose of first maintenance.
Maintenance, sir.
Okay. So BCG failure can be, you should read it, but both answers were technically not so good. BCG refractory, BCG relapsing. Okay, one terminology is BCG unresponsive and the last is BCG intolerant. Intolerant means disease persistent or recurrence, probably due to inability to tolerate or receive the BCG. Okay, so that's BCG intolerant. Now, BCG unresponsive is moreover used as a terminology because we many times discuss the treatment options on basis of that, and that includes BCG refractory and early BCG relapsing. So remember these two things. BCG unresponsive is BCG refractory and early BCG relapse. Okay. You need
Yes.
to read both BCG refractory and BCG relapsing, early and late. क्या होता है?
Yes.
Important thing is, as the BCG goes on, any low grade recurrence during or after therapy is not considered BCG failure. Huh? Many
Yes, sir.
people just equate that any tumor coming up is a failure. Any tumor coming up is not a failure. Okay, so if we have BCG unresponsive, how will we treat?
Sir, we can give another.
Can mat bolna re. Together we can do anything. You tell what you will do.
Sir, then I would like to counsel the patient, and sir, I can give the option of radical cystectomy for this patient. Sir.
Okay, so you say no that you will counsel a patient and give option for radical cystectomy.
Yes.
And what are other options?
Sir,
BCG unresponsive. So one is radical cystectomy. What are other options? Can I give again BCG therapy?
sir, we can try for one cycle of the induction and maintenance.
Again, in BCG unresponsive, it is never given. What is BCG unresponsive? It is BCG refractory disease or early relapsing.
Then, sir, we can start the patient on checkpoint inhibitors.
Yes, you can, but that is technically little lower down the list. You can give HIVEC or you can use intravesical sequential gemcitabine docetaxel. And then we can give, you said which drug?
Sir, checkpoint inhibitors.
Checkpoint inhibitor. So what is the dose of that checkpoint inhibitor?
Sir,
बताओ तो सही. So pembrolizumab is given 200
yes,
milligrams IV every 3 weeks. So the study, I think, I'm not remembering exactly, but I think it was for 24 months, every 3 weeks. Okay. So in BCG failure, if it is late BCG relapsing, then what is the option?
Sir, in that case, we can in late BCG relapsing, we can offer the second induction BCG or radical cystectomy.
Yeah. So if I am in your place, I'll still offer radical cystectomy first because it is BCG failure, and then if patient doesn't want a cystectomy, then repeat course of intravesical BCG. That is correct.
Okay, sir.
Okay. So, gem dossier, anybody is familiar with? Nobody. So you should at least know how to give gem dossier. Okay. Because there are two sequential drugs, right?
Yes, sir.
At least how many grams of each drug is given? That much you can tell me.
So gemcitabine is 1 gram and docetaxel is 37.5.
Correct.
And so gemcitabine, both are given on day first 8, 15, 22, 29 and 36. Then we wait and then we repeat a second cycle after 6 weeks. Then for maintenance for about 10 to 12 cycle we repeat.
Okay, very good. So that's about it. And the checkpoint inhibitor, what I think Rahul said was the trial was Keynote 057. Okay. So one question about early cystectomy. So what is the use technically of early cystectomy? So why should we not wait till we get a muscle invasive disease proper and then go ahead with early
Sir,
cystectomy?
overall prognosis of muscle invasive bladder cancer is poor as compared to non-muscle invasive. So if early cystectomy has been done, it will give overall survival better.
Okay. Any idea how much?
So more than 90%, sir. If it is a muscle invasive, then it's about 60%.
Wow. Okay. You need to read that. The 10-year usual cancer-specific mortality is around 43% in MIBC proper. I have no more questions actually. If we have another case, I think we can go for it.
Yeah. So we have got another, actually multiple cases, but just now we do one more case.
Okay. Otherwise, we can just go for a scenario also. Suppose you do a cystoscopy and you say we had this one tumor, and on the other side you see a diverticulum and a tumor in that diverticulum. So how will you approach that?
Sir, diverticular tumor, I would like to see the size of the tumor, how many tumors are there, whether
it's inside the diverticulum. There is a single diverticulum and a tumor.
Sir, then there is no muscle layer in the diverticulum wall, so it can be upstaged as directly T3A or T3B lesion.
Okay.
So, sir, we can take the biopsy and go for the radical cystectomy for this case, sir.
Okay. So when should we consider partial cystectomy for a diverticular tumor?
Sir, if tumor is small and a low-grade tumor and patient's condition also, sir, age of the patient, performance status of the patient, and these factors we can consider, and then we can go for the partial cystectomy. But results are recurrence rate after the partial cystectomy also, sir, more that sir now in the now sir total cystectomy is better option than the partial cystectomy.
Okay, so in high-grade diverticular tumors, multiple diverticulums and tumors within them,
Then
for a cystectomy.
yes, sir. Then radical cystectomy, sir.
Okay. A case laga hai na already. We'll go with that fast.
Yeah, go. Yeah, we go ahead. Now another
70 years male with painless hematuria. That's it. Chalo, that is your
So
history.
who is answering now? There are other two candidates.
Harsh.
Harsh,
make yourself available. Chalo.
Harsh
Yes, sir.
Oh, Harsh
who
has
is
gone.
answering? Harsh and
Dr. Anuj.
Somebody call Harsh and get him on the
Yes, sir.
screen.
I'm online.
Yes, thank you, Harsh, for waking up.
and Aditya is
तुम्हारा
answering.
chance हो गया है. Harsh and Brijesh are answering now.
Anuj.
70-year-old male with painless hematuria. आगे का history दिखा दो. I think let's see. Because history we have discussed in detail in the last case, so there's no point repeating. So roughly, we don't have anything positive, right, in the history other than that.
Yes, sir.
Yes. Right, sir.
So Brajesh, how is smoking related to bladder cancer? What is the ORR, objective risk rate?
Harsh, answer.
So 2 to 6 times the risk of bladder cancer with smoking.
2 to 6 times than the normal population.
Than the normal population, yes.
Okay. Okay. So how will you go ahead with this case now? How will you investigate?
Would like to do a complete lab investigation with CBC. Urine routine is already done. Do a renal function test, check for his creatinine. Also, would like to do a serum PSA. Would like to do a urine cytology when there is no episode of gross hematuria, and would like to do a ultrasonography of the abdomen and pelvis.
So I don't know, but do you think one of the diagnoses of hematuria is also UTI, no?
Yes, sir.
So do you want to do a PSA?
So PSA, since there are pus
Many
cells right
times,
now,
I
we
mean,
can.
there can be infection, there can be
Yes,
hematuria,
yes,
something.
right.
So
So
do PSA.
yes.
Go on.
So would like also like to. So urine cytology has been shown. So urine cytology is no malignant cells. I would also like to do an ultrasonography of the abdomen and pelvis. I would like to evaluate the kidneys, ureter, bladder.
Okay, here you
Uh,
can be asked the same question which we discussed last time. Want to do a sonography, want to do a CT urography, so no problem. Go ahead with your sonography. I think he has shown you uroflowmetry.
yes. So uroflowmetry has a maximum flow of 13.1 with a voided volume of 130 ml, and suggest it has an equivocal pattern of obstruction. And yeah, would like to see the sonography.
So patient has voided only 130 ml, if I'm mistaken.
Yes.
Go on
So
that
ideally 150 ml is
Go on that
required.
uroflowmetry.
So ideally 150 ml would be required, but so would like to repeat the uroflowmetry also, but this
So
gives a
be very
rough
careful
idea.
when you interpret all these uroflowmetries in detail.
Right.
So you can say that what you said right now.
Would you like to repeat it? Repeat the
I
flow
would
meter.
like to repeat
Yeah.
it, but in the given report, it is like this with 130 ml void. Otherwise, people will ridicule you.
Right.
Okay. Next report. क्या दिखता है?
In the given sonography, the bladder appears well distended with a mass lesion seen in the left posterior lateral wall of the bladder with a broad base and otherwise with a thickened bladder wall. And
Always remember in exam, I can't see on my laptop, but sometimes the measurement is given on the side.
right.
In case you see the measurement, it is best to say those dimensions when you're describing the mass. Mass matlab in sonography, it is a hyperechoic lesion probably.
Right.
So it doesn't seem papillary. It seems kind of broad-based.
Broad-based and yeah.
And I can't see the size dimensions.
Size dimension is not mentioned. Sir.
Not mentioned. Okay.
Yeah, you can appreciate some hydronephrosis in the left kidney.
Is it? Okay.
Yes.
Okay. So what does hydronephrosis mean? Suppose
there is
in a
possible
case of
involvement.
bladder mass on that side.
So there's a possible involvement of the bladder mass involving the ureteric orifice, which is causing a back pressure change and causing a hydronephrosis.
Okay.
The other possibilities are there's an
What are
advanced
the
bladder cancer.
possibilities? What are the conditions causing hydronephrosis in a bladder mass?
So it can be obstructing the ureteric orifice. It can be a terminal ureteric mass, which is
Can be a
causing
terminal ureteric mass.
or it
Can
could
be
be
a
an
bladder
advanced
mass
bladder
which is just
malignancy.
falling on the ureteric orifice and obstructing it.
Yes.
Or
advanced bladder malignancy with an extravesical spread, it can be an indicator of an advanced bladder malignancy. Basically.
It is an indirect evidence of muscle invasion.
Muscle
That is
invasive.
the third
Yes.
thing.
Yeah.
So two things were right. The third thing is at the site of ureteric orifice, there can be a muscle invasion of the bladder tumor, and it is causing obstruction of the lower ureteric orifice or the lower ureter itself,
right.
as the ureter travels into the bladder wall.
Bladder, yes.
In the past, they used to ask a question in the exam, any indirect sign of muscle invasion, or they used to ask any of the signs where you will directly go for CT. Sometimes they used to ask like that in the question. So broad-based tumor, hydronephrosis, tumor grossly going outside the bladder. Such cases, earlier they used to always have a discussion whether TURBT first or CT first.
So Harsh, next test.
So, would like to go ahead with a contrast enhanced CT scan of the abdomen and pelvis with the excretory images, and would also like to do a CT scan of the thorax. So,
CT scan
ultrasound is suggestive of
थोड़ा सा
a
sequentially भी कर सकते हैं.
okay. Ultrasound has a average filling capacity of the bladder with, apart from the focal heterogeneous thickening seen posterior lateral wall around left VUJ measuring 27 by 13 mm with vascularity on Doppler. Yeah. And both kidneys are appearing of normal size with no space occupying lesion. And you can see some few granules around the parenchyma and stone measuring 5 mm in the right kidney upper pole. Yeah. And 2 cysts seen in each kidney, lower poles. With the left kidney showing back pressure changes in the form of dilated renal pelvis and whole course urine.
Okay. So what does it do?
So it's probably a muscle invasive bladder cancer involving the left ureteric orifice with the left hydronephrosis.
Okay, so Brajesh, what will you do? Brajesh was answering with you, no?
Not Brijesh.
Brijesh.
Who is answering?
I don't know. I thought Brijesh
Dr.
was
Anuj.
answering. Okay, Harsh, go on. No problem.
Yeah, so like to go ahead with the CTs.
अभी CT scan हो गया ना?
It's sonography.
Okay, okay. चलो ठीक है. Sorry. हाँ, पढ़ो.
CT scan दिखाओ.
Bilateral kidneys are showing normal uptake.
Bilateral kidneys are normal uptake.
Left kidney is showing moderate hydronephrosis with moderate with the dilatation of the upper ureter. Would like to see the on the excretory images. So
Bharat, unmute yourself and you also start answering.
Yes, Paras, start answering.
We can see a lesion in the left posterior lateral wall of the bladder, which
you see a
seems to be
sessile
involving the
broad-based
left
lesion.
ureteric orifice.
Yeah,
and
I think I
left
kind
VUJ.
of see the ureter also in one of the lesion coming there.
Yes, it's
I
involving
need
the
to
left
see more
terminal
images,
ureter.
but I think there is a ureter there.
Yes.
Okay, so
Brijesh, show the next film.
Appears broad-based and broad-based sessile and
So
Yes,
what?
sir.
Lymph nodes वगैरह कुछ बोला नहीं, कुछ नहीं. Lymph node.
yeah. So there doesn't appear to be a.
Doesn't appear to be what? Liver में भी lesion दिख रहा है.
We are unable to zoom in, sir.
बराबर. Next time ना CT scan images है ना एक image एक slide पे लगा दो.
Exactly. Paras, can you read and yeah.
Okay. चलो, we'll go over the next image. Next slide पे क्या है? Harsh,
so CT
scan you answered only on the lesion.
Yeah.
You didn't mention anything on the perivesical. You didn't answer about lymph nodes. You didn't see the adjoining other organs. मतलब organ spread generally and liver at least.
Liver appeared grossly unremarkable, sir.
and which nodes are metastatic retroperitoneal. You are supposed to answer everything.
Right. So mass lesion involving mass lesion seen as enhancing wall thickening with an endovesical polypoidal component involving the left posterior lateral wall of the bladder, including the left VUJ and intravesical segment of the distal ureter with resultant upstream moderate hydronephrosis. Lesion appearing 3.9 by 1.2 centimeter in axial plane and 3.3 centimeter in SI, and it's close to the left seminal vesicle. Any calculation right upper calyx, mild prominence of right PCS and upper right ureter. However, no calculus seen. Right kidney appears normal, left kidney appears normal. Both kidneys are otherwise normal in size. It shows good nephrogram from
Hmm. So now what?
Paras, what you want to do?
Paras किधर है? Paras.
Yes, sir, I would like to proceed with cystourethroskopy and PURBT.
Cystourethroskopy and TURBT under anesthesia तो बोलो.
Under general anesthesia with deep muscular.
Do you also want to keep URS standby?
So mostly the lesion is not encroaching the ureter, sir.
Okay. But
So
रख
you
लेना
can't say
standby.
ना.
अगर examiner
Yes,
इतना
sir.
बोल रहा है तो रख दे table पे.
Yes.
Sometimes if you see tumor coming out of the ureter, you may want to put NC inside, no? Or
Yeah,
take
at least
biopsy
you would
or
want to see how much it is going inside, how long.
yeah.
Yes, sir.
Okay.
See, the important thing is the general answer everyone will give. But this type of advanced answer, only, people like
Only
you
our
will,
students should give.
yeah. So, definitely. So, you should have an age over person.
Okay. चलो तो cystourethroskopy and TURBT. Next slide.
Vijay,
Harsh, you agree
yeah.
with the same procedure or different something?
Yes, sir. Would like to go ahead with this one.
Okay. Paras, what irrigation fluid you are going to use?
Sir, I would like to do a monopolar TURBT, so I would like to use glycine.
Glycine. Okay. Harsh, what will you use?
So glycine or distilled water also can be used. Sterile
In
water.
TURBT, you use always distilled sterile water.
Hello.
Yeah, sterile water.
Glycine is used for TURPs. And
Either
sterile
of
water is
sterile
used
water
in
preferably.
TURBT. Glycine has a 1.5% glycine has a purpose to be used in TURPs because there is intravascular absorption. In bladder tumors, there is no absorption. Okay. And we use sterile water because it gives that small clarity and also because it is considered that sterile water is damaging to the cells.
Yes.
Okay. Somebody read that.
So it's the same report, sir. Mass lesion
mass lesion.
seen in the mass lesion seen as an enhancing wall thickening with endovesical polypoidal component is seen involving the left posterior lateral wall of the
Same
urinary
लगा है
bladder.
नहीं इसमें?
Same है, same.
सिर्फ dimension भूल गए हैं, बाकी
Put
सब
the
same.
cystoscopy findings, no? Brijesh, go ahead.
हाँ, ahead. Next slide, man.
Brijesh.
Okay, findings नहीं, इसने diagnosis दे दिया, चलो. हर्ष पढ़ो वो.
So histopathology की suggests of marked thermal artifacts show a high-grade urothelial carcinoma with lamina propria invasion seen, and few foci suspicious for deep muscle involvement are noted.
Okay. So
Paras, now what is your diagnosis? Is it, again, the same question. Is this pathology description proper or you want to know more things?
They have written it is suspicious of deep muscle involvement. So I would like to review it, the slides, or we can do a restage to URBT.
okay, both answers good.
Right analyze me.
Yes. Harsh, what you want to do? You want to go to the pathologist and find out anything else in this pathologist like?
One would be I would like to confirm for the deep muscle involvement. So yeah, restaging to URBT in this case.
So Harsh, I want to ask you one question. With the report, the way it is written, why I should not believe that it is muscularis mucosa and not the other one? So in all, my question is, what is the difference between muscularis mucosa and muscularis propria?
So muscularis propria is the main detrusor muscle, sir, and muscularis mucosa it's a part of subepithelial lamina propria.
Correct. Definition wise, perfect. But how will
The deep
pathology?
muscle, they've sent for the probably sent for the deep muscle separately. So suspicious for deep muscle involvement probably from this other biopsy also that is possible.
What sir wants to know is that when there is muscularis propria, then it means that it is deep muscle involvement. That is what he should have answered.
So basically, muscularis mucosa is a thin
Is a
layer
thin layer, yes.
within the connective tissue of the lamina propria.
Subepithelial.
And muscularis propria is seen as very compressed, thick bundles of striated muscle proper. Remember that. I'm just asking you about the pathological value. Like sometimes it happens that somebody has seen muscularis mucosa as a pathologist and reported as deep muscle invasion.
Many times in the report also they write Ganesh bhai. We have to
Correct.
clarify with the pathologist.
So, वही बोल रहा हूँ मैं इनको कि that was the intent of the question.
Correct, correct.
Okay, so
what do we
do next?
I would like to have a final histopathology report, sir, if it is muscle invasive or not.
So you
कुछ है
want
क्या?
to do re-QRBT?
Yes, I would like to review the slide, or we can do a restaging TURBT and know the final histopath.
So what was done, Brijesh?
So review was done. It suggested of deep muscle involvement.
Bharat, now next what?
Sir, now I would like to offer patient.
Is your metastatic workup complete, Paras?
Yes, sir. Wait,
Comment on that, no?
I would like to do a metastatic workup. So in form of CT chest. CT abdomen has already been done.
But there was some doubtful lesion in the liver. Would you like to know more about it?
No,
Chest
it was
also.
tiny calcification.
Okay. Remember in the exam, before you say final treatment, you should think about all these things.
And the CT test is normal.
Go ahead now. What else will you do? Now it's done.
So I would counsel the patient about the treatment of radical cystectomy with a diversion.
Patient is concerned now about lymph nodes. Somebody has told him in his family, lymph
Yes,
nodes are there.
the radical cystectomy with lymph node dissection plus urinary diversion.
Any role for neoadjuvant? Patient's relative has told him.
So there is a role for neoadjuvant chemotherapy. So in case of a lesion more than T2A or N1 lesion, the neoadjuvant chemotherapy has a 5% overall survival benefit.
So what was this lesion? You did not stage also.
Paras, the ABC meta-analysis which you are quoting, the inclusion criteria is PT2 to T4 N0.
That is what I'm bringing your attention. You did not stage.
When doctor, when Hiren sir says lymph node positive, technically N1 or N2 disease, whatever. So it is considered as such locally advanced in the bladder and it goes straight forward for chemotherapy.
Yes.
The
Okay.
new adjuvant is described in PT24N0. And there is a 8% benefit seen in.
So now just take a deep breath and think that before answering in the exam, you have to think about metastasis, metastatic workup, and staging. Then you start offering treatment.
T2A to T4A, sir, N0.
I am
But ये
focusing
N0
on
नहीं है
N0
ना?
only, Baba.
But
Yes.
this is not N0 ना?
So,
Okay, what we are trying to tell is, I mean, remember all the in urology इतने खास कुछ trials नहीं रहते, so you try to remember exactly what you are speaking. वो जो data, what you said 5% वगैरह is considered from the new adjuvant for T24 N0, not N1. Okay, so what chemotherapy do you propose?
the cisplatin and gemcitabine combination.
Okay.
So since the patient creatinine is also low.
Anybody can say the Galsky criteria?
Yeah, so the ECOG score should be less than equal to 2. The creatinine clearance should be more than 60. So the neutrophil count should be a CTCA score less than 2, and this audiometry less than 2, and NYHA heart more than 3. Less than 3, sorry.
When you know all this, then
Remember,
you're talking only of creatinine.
Galsky criteria is for eligibility for cisplatin. Okay. So how many cycles are considered? Node positive bladder cancer. Yes, please.
So 2 cycle, and then we should restage. If there is response, then we
Restage
can
nahi re, reassess.
reassess. Reassess, and if there is response, then we can go for surgery. Maximum we can go for 4 cycles.
So this is node positive. If node positive this is there, it is better to go for 4 cycles. ऐसा कोई रूल नहीं है कि 2 cycles के बाद you go for surgery, even in the other one. So neoadjuvant chemotherapy is considered 3 to 4 cycles. So many times when 3 cycles are given and you go for surgery, some medical oncologists give the 4th cycle later.
Yes.
So इसमें और कुछ है केस में?
नहीं, I think that is end.
Okay. So मतलब generally we are at MIBC. So
Yeah. No problem. Next time we will take the.
We'll do a metastatic, sir. Metastatic disease.
चलेगा.
ठीक है.
Whatever
Next
मतलब
time.
metastatic इनको रहेगा नहीं एग्जाम में, I think ना?
हाँ, right. वो तो
नहीं.
ज्यादा ऑन्कोलॉजी के लिए होगा.
मेटास्टैटिक में इनका टाइम वेस्ट हो जाएगा.
Right. Okay.
नहीं, we will. So if we get multiple cases, small cases, just
हाँ वो
scenarios.
कर सकते हैं. पटापट scenarios, because we have discussed umpteen number of history and imaging now today.
Correct. So only the scenarios, and you just like an answer.
We can do some cases, variant histology वगैरह ऐसे कुछ बात
Yes.
कर सकते हैं.
Okay. So we'll find out all this. And you also, if you get some cases, please, you know.
Sir, lymph node dissection only standard or extended?
You tell now what is the
Bit
role
about
of both.
standard versus
Explain.
extended.
You explain what is the difference between the two. Paras.
So in standard, we take the hope group of lymph node and up to the crossing of the ureter, and in extended till the bifurcation.
So that
of
is the landmark, but what is the indications and results?
Results
standard.
for standard, the standard and extended super extended all have the same overall survival, but only there's a difference in the recurrence-free survival of around 15% of extended and super extended over standard.
So standard, I think, in bladder consists of external iliac obturator,
Internal iliac,
internal iliac,
presacral.
up to the common iliac, not the ureter crossing.
Not involving the
And extended is considered up to the bifurcation of aorta. But many places they will do a dissection up to the ureter crossing along with presacral nodes, which will kind of remove at least 80 to 85% of the nodal drainage in bladder. So as Harsh said, there is no actual
Survivor benefit.
survival benefit. But an easy answer probably either of you can give. Harsh, what is your answer for the lymph node dissection? Harsh.
Standard lymph node dissection.
Okay. So it is, I would say, as an institutional protocol, I do extended up to ureter crossing, which will include external, internal iliac, obturator, and presacral, both sides. And if I have enlarged nodes in these, I would definitely go up to the bifurcation of aorta. So this is my answer. I don't know whether you like it or not, but this is how I would say as my institutional protocol. So examiner will never consider you wrong. हर्ष
Yes, sir.
हर्ष है क्या?
हाँ, sir, yes.
Yes, yes.
हाँ तो ये मैंने कितनी बार सिखाया तेरे को? Okay, anything else? Follow protocol वगैरह if you want we can do next time.
Yeah. So next time we'll keep another 3-4 cases, short cases, and then we'll see. Okay.
Okay.
So I'll be in contact with you. You also, Harsh, sir के पास case लेके तैयार कर देंगे.
Harsh, you're listening?
Yes, sir.
हाँ तो Harsh,
And
your
you are
final
answering
question.
well. Huh?
What is the
Ganesh
follow-up
is-
protocol for low risk NMIBC?
Follow-up protocol.
Loudly, I cannot hear.
So urine culture, urine cytology and cystoscopy at 3 months and 9 months. And
Fail. Low risk
for low risk.
NMIBC, there is no urine cytology.
So cystoscopy at 3 months and
Cystoscopy
then
at 3
at
and 9 months.
12 months and then yearly for 5 years.
Yearly for 5 years.
Cystoscopy at 3 months, if normal at 9 more months, which will be 12 months, and then annually, if everything keeps
Perfect.
on going normal, annually up to 5 years. Paras, you remember,
Yes,
answer it that way.
Okay. So for intermediate, it is 3 months for 2 years, and then if it is everything is normal, then
I
yearly.
think it is always better to talk about follow-up protocol of high risk NMIBC first, after low risk, and then say that the follow-up of intermediate risk NMIBC protocol is in between both, tailored to an individual patient. Okay?
Yes.
That's a better answer again. So I think you should try to learn to answer in this manner in the exam.
Yes.
What is well defined, low risk and high risk? What is not so well defined, intermediate risk? So use that. Okay. Good night, everybody. Good night, sir.
Good night.
Good night, Ganesh bhai.
Good night.
Good
Bye,
night,
Hiren.
Gaurang sir.
Good night.
Good night, Ganesh. Wonderful session.
Very good session. Huh? Ganesh, thank you very much. Ashrafi, thank you. And always, Dr. Pankaj Maheshwari, thank you very much.